Good afternoon, ladies and gentlemen. My name is Chris Wilson. I'm the Communications Director here at the DFW Hospital Council. Normally, my President CEO, Stephen Love, will be here to provide the intro, and he got called away to a meeting last night, and he sends his apologies. He was really looking forward to this presentation, but we're going to move forward. We're looking very forward to Dr. Indira Tyler's presentation, The Influence of the Social Determinants of Health. We're hosting this webinar in coordination with Herzing University. They're an associate member of the council. Herzing University is a private university with multiple locations throughout the U.S., including an online division. The university offers associate, bachelor's, master's, and doctoral degrees. Students have the option to attend one of the campuses in eight different states, or they can earn their healthcare degree fully online. Today, our guest speaker, as I noted earlier, is Dr. Indira Tyler. She's a faculty development specialist at Herzing University. She's involved in research on topics such as cancer, fatalism, and culturally targeted interventions. She is also a registered nurse and worked for many years at the bedside. She has degrees from the University of Notre Dame and Hampton University, and we are looking forward to her presentation. Today, we will explore the influence of the social determinants of health in shaping health outcomes for communities. We will also discuss how factors like economic stability, healthcare access, and neighborhood environments can significantly impact healthcare. Before we begin, please note we will be taking your questions. Please type them into the question box and we'll answer them before the end of the webinar. And with that, ladies and gentlemen, here's Dr. Indira Tyler.
Good afternoon, everyone, and thank you for that great introduction. This topic has been on my conscience and has impacted how we integrate scenarios and experiential learning for our students. And so I want to really get into the topic and let's look at how the influence of social determinants of health shape health outcomes for individuals and communities. We're going to discuss how factors like economic stability, education, healthcare access, and neighborhood environments can significantly impact health. And we're going to really look at how um, we explore how Herzing University incorporates reflective practice and social determinants of health in case studies as a pathway to prepare a healthcare students and get them ready for practice. So we're going to discuss how factors really impact health, those key concepts of social determinants of health, um, economic stability, education, healthcare access, and environmental factors. We're going to recognize the barriers to health facing patients and their families from diverse socioeconomic backgrounds and analyze how uh, social determinants of health can impact patients' health outcomes. And then look at a tool such as reflective practice and how it can illustrate empathetic engagement of patients and their families and help them to mitigate the effects of social determinants of health on their health outcomes. So let's get started. So, according to the World Health Organization, people living in countries with the highest life expectancy will live 33 years more than those born in countries with the lowest health life expectancy. And even within countries, life expectancy varies by decades, depending on which area you live in and the societal group in which you belong. So, health and illness follow a social gradient. People who have limited access to quality housing, education, social protection, and job opportunities have a higher risk of illness and death. And the research indicates that these social determinants can outweigh genetic influence and healthcare access in terms of their impact on health. So it goes along with that saying your zip code is more important than your genetic code. Even as we consider the American Association of Colleges of Nursing, those key things that outline and provide pillars to our education that we provide to our nursing students, they've identified that social determinants of health contribute to a wide health disparities and inequities in areas such as economic stability, education quality and access, healthcare quality and access, and neighborhood and built environment and social and community contexts. So, as we engage with our nursing students, we also have to identify that nursing practices that they're going to learn with us, such as assessment, health promotion, access to care, teaching our patients in supportive environments, really do improve health outcomes. So, when our students consider employment options, we have to remind them to have a sense of community that they will serve because that is of importance. And as outlined by the AACN, cultural competence is an essential component of our nursing education. And the standard is that nursing program graduates know the community they will serve and possess awareness, knowledge, and skills to provide high quality, patient centered care to diverse populations. And when we create a culturally competent workforce that demonstrates empathy, then there's a desire to provide, really good care, and that provides a positive encounter with the patients that this graduates will see. So we have to take a step back and think, where does health start? So quickly, to get an overview of a community, when we engage in community health courses or public health professions, and especially in the nursing curricula, we do a activity called the windshield survey, and it's often conducted to really get some information about a community. The windshield survey is a method of observing and collecting data about a neighborhood or community by just driving through um, a couple of blocks, the surrounding areas from a designated spot, and assess the physical environment, the social conditions, and the available resources. The windshield survey provides a visual of the overall community's characteristics and may inform about potential health needs, because health starts in our homes, it starts in our schools, it starts in our communities. And as we go through and really evaluate the conditions of a neighborhood or a community, we can then really identify as healthcare providers where our focus should be in addressing health risks and thinking about how to impact health outcomes for that community. And it goes back to realizing that there are characteristics that inform and engage and impact our health, our income level, our educational opportunities, occupational and safe workplaces, gender inequality, if there's racial segregation, access to quality housing and utility services, the impact of good, healthy sources of food are really impacting our health. So, when we are engaging with our students at Herzing University, we start to ask them questions and help them to start to uh, conceptualize, when these components exist, how does that impact the individual? How do these components contribute to health inequalities? And when we are, giving them these broad questions to address, we often try to narrow it down and give them an example of how social determinants of health can have an impact on a family. And here's one of the um, real life videos that we share with them that I'll share with you.
Food that we buy lasts about 2 weeks. We spend like $125, $175 a month for groceries, if not more. I've got like 3 teenagers, so, and, about the end of the month, I start reducing to 1 meal a day so that I can make sure those kids got everything they need. You just do what you can, to survive. I mean, that's about all it is survival. We really don't go too far out of the realm of what's necessary. Snacks aren't something we buy a lot of. I mean, I just go along and see what's the less expensive. How much can I feed? How many people can I feed for that amount of money? Those types of things. I spend a lot of time in frozen foods. I mean, when you get these, the family size, and they're $1.99, and you can feed 4 people with it, versus maybe 4 with $4. I mean, what's your choice is going to be? Especially when you're on a $200 a month budget for food. You can't go down there and buy a 5-pound bag of oranges because that might be 2 meals for 1 bag of oranges. I'm sorry, I'm not going to do that. That's the reason why I think a lot of people that are disadvantaged are unhealthy. And a lot of times you borrow from your bill money, which puts you behind in your utility bills. You worry about, do I buy food or do I have electricity? Okay, if I can only send them this much, are they going to keep my power on, or my gas, or my water? We never skimp on the rent. The rent's something that, if nothing else, we'll have a roof. Of course we're dying young, 60 years old here versus 80 in the eastern section of the county, because those people are more affluent. We don't have a whole lot of choices. You do what you can. And breaking out of it is not easy. No. I read the book, Don't Sweat the Small Stuff, and it's wonderful, but you're not living my life. Small stuff, it doesn't exist in my life because my life is like everything's large. There's illnesses, there's worried about food, there's worried about what I'm going to have, utilities, those are what I stress about. And it's every day. It never goes away. Because you think, well, the kid needs a new coat, okay? What can I borrow from to get this child a new coat? It's always something's going to lose so that something else can be gained. And it's tiresome. I wake up every day and I think, okay, I got one more day. What am I going to do with this day? And there's days when I wake up and I'm like, oh God, not another day. There's times when you get so down. You think, Lord, this life's not worth living. Just let me go sleep. I don't want to wake up. But you wake up and you keep fighting and you hope that maybe that day will be a turnaround. It never is, but you hope it is, And as long as you've got hope, as long as you don't give up. And I think that's part of the reason why I still move around like I do. Because I'm not going to let it beat me. It's going to have to get a whole lot worse. I mean, I'm standing here right now, it's like, air is getting a little thin. But I'm not going to let it whoop me.
So that video highlights the decisions that families with lower socioeconomic status make and how they work within their monthly budgets. It becomes real, and it very well raises awareness about the struggles that many families face. That video highlighted food insecurity for a family in one of the poorest areas of the country. Um, but most recently, like 5 years ago, seems like it was yesterday, we were, as a country, really faced with a very real health scare, a pandemic. And with COVID, we're reminded that the social determinants of health really do have a significant impact on health outcomes. And some those health inequalities that already existed were exacerbated by this pandemic. And we were really um, forced to really kind of see it every day, right? So these lines at food banks really were an everyday uh, news highlight, and it became very evident that um, many people were very, very close to um, feeling the effects of this impact of the pandemic, and that social determinants of health really are impacting a large number of us, whether it's food insecurity, inadequate housing, um, and the limited access to healthcare can be very widespread, affecting an increasing number of people. And given these barriers to health, um, what can we really think about and how can we really address it? What can we do? So, I will talk a little bit about the World Health Organization and bringing them back into the focus of how to address the social determinants of health. They recognize that challenges are there and they can be overcome, but we have to really look at these social determinants of health in a very complex, multifaceted field because it is. And it voiced a wide um, range of stakeholders to come together and really think about how do we address it. And there's evidence that social determinants of health, um, in trying to identify how to address it, has strengthened over the years, the past decade particularly, and that evidence has identified good practices to disseminate even more effectively. And there are three areas of critical action identified by a World Commission on Social Determinants of Health, as is commissioned by the World Health Organization, and to reflect on how to really tackle these inequities. One of the things that they identified is improving daily living conditions, tackling the inequitable distribution of power, money, and resources. But it's the third one that I think in our area that we, nursing education, that we can really focus on and have a good impact. And it talks to understanding the problem and assessing the impact of your action. It specifically states to expand the knowledge base and to develop a workforce that is trained on social determinants of health and raise public awareness of social determinants of health and how they impact um, health outcomes. So it's focusing on expanding knowledge, which I think is very important. So let's think about how we can make an impact. And I found this TED Talk that really asks, what if our healthcare actually helped to keep us healthy?
My energy bill dropped from $150 to $50 by doing this. My friends laughed at me when I spent $49.
Skip that.
So my freshman year of college, I signed up for an internship in the housing unit at Greater Boston Legal Services. Showed up the first day ready to make coffee and photocopies, but was paired with this righteous, deeply inspired attorney named Jeff Purcell, who thrust me onto the front lines from the very first day. And over the course of 9 months, I had the chance to have dozens of conversations with low-income families in Boston who would come in presenting with housing issues, but always had an underlying health issue. So I had a client who came in about to be evicted because he hasn't paid his rent. But he hasn't paid his rent, of course, because he's paying for his HIV medication and just can't afford both. We had moms who would come in, daughter has asthma, wakes up covered in cockroaches every morning. And one of our litigation strategies was actually to send me into the home of these clients with these large glass bottles. And I would collect the cockroaches, hot glue gun them to this poster board that we bring to court for our cases. And we always won because the judges were just so grossed out. Far more effective, I have to say, than anything I later learned in law school. But over the course of these 9 months, I grew frustrated with feeling like we were intervening too far downstream in the lives of our clients, that by the time they came to us, they were already in crisis. And at the end of my freshman year of college, I read an article about the work that Dr. Barry Zuckerman was doing as chair of pediatrics at Boston Medical Center, and his first hire was a legal services attorney to represent the patients. So I called Barry, and with his blessing, in October 1995, walked into the waiting room of the pediatrics clinic at Boston Medical Center. I'll never forget the TDs played this endless reel of cartoons, and the exhaustion of mothers who had taken 2, 3, sometimes 4 buses to bring their child to the doctor was just palpable. The doctors, it seemed, never really had enough time for all the patients, try as they might, and over the course of 6 months, I would corner them in the hallway and ask them a sort of naive but fundamental question. If you had unlimited resources, what's the one thing you would give your patients? And I heard the same story again and again, a story we've heard hundreds of times since then. They said every day we have patients that come into the clinic, child has an ear infection, I prescribe antibiotics, but the real issue is there's no food at home. The real issue is that child is living with 12 other people in a 2-bedroom apartment, and I don't even ask about those issues because there's nothing I can do. I have 13 minutes with each patient. Patients are piling up in the clinic waiting room. I have no idea where the nearest food pantry is, and I don't even have any help. In that clinic, even today, there are 2 social workers for 24,000 pediatric patients, which is better than a lot of the clinics out there. So Health Leads was born of these conversations, a simple model where doctors and nurses can prescribe nutritious food, heat in the winter, and other basic resources for their patients the same way they'd prescribe medication. Patients then take their prescriptions to our desk in the clinic waiting room, where we have a core of well-trained college student advocates who work side by side with these families to connect them out to the existing landscape of community resources. So we began with a card table in the clinic waiting room, totally lemonade stand style. But today we have 1,000 college student advocates who are working to connect nearly 9,000 patients and their families with the resources that they need to be healthy. So 18 months ago, I got this email that changed my life. And the email was from Dr. Jack Geiger, who had written to congratulate me on Health Leads and to share, as he said, a bit of historical context. In 1965, Dr. Geiger founded one of the first 2 community health centers in this country in a brutally poor area in the Mississippi Delta. And so many of his patients came in presenting with malnutrition that he began prescribing food for them. And they would take these prescriptions to the local supermarket, which would fill them and then charge the pharmacy budget of the clinic. And when the Office of Economic Opportunity in Washington, D.C., which was funding Geiger's clinic, found out about this, they were furious. And they sent this bureaucrat down to tell Geiger that he was expected to use their dollars for medical care. To which Geiger famously and logically responded, "The last time I checked my textbooks, the specific therapy for malnutrition was food." So when I got this email from Dr. Geiger, I knew I was supposed to be proud to be part of this history. But the truth is, I was devastated. Here we are 45 years after Geiger has prescribed food for his patients, and I have doctors telling me, on those issues, we practice a don't ask, don't tell policy. 45 years after Geiger, Health Leads has to reinvent the prescription for basic resources. So I have spent hours upon hours trying to make sense of this weird Groundhog Day. How is it that if for decades we had a pretty straightforward tool for keeping patients, and especially low-income patients, healthy, that we didn't use it? If we know what it takes to have a healthcare system rather than a sick care system, why don't we just do it? These questions, in my mind, are not hard because the answers are complicated. They are hard because they require that we be honest with ourselves. My belief is that it's almost too painful to articulate our aspirations for our healthcare system or even admit that we have any at all, because if we did, they would be so removed from our current reality. But that doesn't change my belief that all of us, deep inside, here in this room and across this country, share a similar set of desires. That if we are honest with ourselves and listen quietly, that we all harbor one fiercely held aspiration for our healthcare, that it keep us healthy. This aspiration that our healthcare keep us healthy is an enormously powerful one. And the way I think about this is that healthcare is like any other system. It's just a set of choices that people make. What if we decided to make a different set of choices? What if we decided to take all the parts of healthcare that have drifted away from us and stand firm and say, no, these things are ours. They will be used for our purposes. They will be used to realize our aspiration. What if everything we needed to realize our aspiration for healthcare was right there in front of us, just waiting to be claimed? So that's where Health Leads began. We started with the prescription pad, a very ordinary piece of paper, and we asked not what do patients need to get healthy, antibiotics and inhaler medication, but what do patients need to be healthy, to not get sick in the first place? And we chose to use the prescription for that purpose. So just a few miles from here at Children's National Medical Center, when patients come into the doctor's office, they're asked a few questions. They're asked, are you running out of food at the end of the month? Do you have safe housing? And when the doctor begins the visit, she knows height, weight, is there food at home, is the family living in a shelter? And that not only leads to a better set of clinical choices, but the doctor can also prescribe those resources for the patient using Health Leads like any other subspecialty referral. The problem is, once you get a taste of what it's like to realize your aspiration for healthcare, you want more. So we thought, okay, if we can get individual doctors to prescribe these basic resources for their patients, could we get an entire healthcare system to shift its presumption? And we gave it a shot. So now at Harlem Hospital Center, when patients come in with an elevated body mass index, the electronic medical record automatically generates a prescription for Health Leads. And our volunteers can then work with them to connect patients to healthy food and exercise programs in their communities. We've created a presumption that if you're a patient at that hospital with an elevated BMI, the four walls of the doctor's office probably aren't going to give you everything you need to be healthy. You need more. So on the one hand, this is just a basic recoding of the electronic medical record. And on the other hand, it's a radical transformation of the electronic medical record from a static repository of diagnostic information to a health promotion tool. In the private sector, when you squeeze that kind of additional value out of a fixed cost investment, it's called a billion-dollar company. But in my world, it's called reduced obesity and diabetes. It's called health care, a system where doctors can prescribe solutions to improve health, not just manage disease. Same thing in the clinic waiting room. So every day in this country, 3 million patients pass through about 150,000 clinic waiting rooms in this country. And what do they do when they're there? They sit, they watch the goldfish in the fish tank, they read extremely old copies of Good Housekeeping magazine, but mostly we all just sit there forever waiting. How did we get here where we devote hundreds of acres and thousands of hours to waiting? What if we had a waiting room where you don't just sit when you're sick, but where you go to get healthy? If airports can become shopping malls and McDonald's can become playgrounds, surely we can reinvent the clinic waiting room. And that's what HealthLeads has tried to do, to reclaim that real estate and that time and to use it as a gateway to connect patients to the resources they need to be healthy. So it's a brutal winter in the Northeast, your kid has asthma, your heat just got turned off, and of course you're in the waiting room of the ER because the cold air triggered your child's asthma. But what if instead of waiting for hours anxiously, the waiting room became the place where HealthLeads turned your heat back on? And of course, all of this requires a broader workforce. But if we're creative, we already have that too. We know that our doctors and nurses and even social workers aren't enough, that the ticking minutes of healthcare are too constraining. Health just takes more time. It requires a non-clinical army of community health workers and case managers and many others. What if a small part of that next healthcare workforce were the 11 million college students in this country? Unencumbered by clinical responsibilities, unwilling to take no from an answer from those bureaucracies that tend to crush patients, and with an unparalleled ability for information retrieval honed through years of using Google. Now, lest you think it improbable that a college volunteer can make this kind of commitment, I have 2 words for you: March Madness. The average NCAA Division I men's basketball player dedicates 39 hours a week to his sport. Now, we may think that's good or bad, but either case, it's real. And HealthLeads is based on the presumption that for too long, we have asked too little of our college students when it comes to real impact in vulnerable communities. College sports teams say, we're going to take dozens of hours at some field across campus at some ungodly hour of the morning, and we're going to measure your performance and your team's performance, and if you don't measure up or you don't show up, we're going to cut you off the team. But we'll make huge investments in your training and development, and we'll give you an extraordinary community of peers. And people line up out the door just for the chance to be part of it. So our feeling is, if it's good enough for the rugby team, it's good enough for health and poverty. HealthLeads, too, recruits competitively, trains intensively, coaches professionally, demands significant time, builds a cohesive team, and measures results. A kind of teach for America for healthcare. Now, in the top 10 cities in the US with the largest number of Medicaid patients, each of those has at least 20,000 college students. New York alone has 500,000 college students. And this isn't just a sort of short-term workforce to connect patients to basic resources. It's a next-generation healthcare leadership pipeline who have spent 2, 3, 4 years in the clinic waiting room talking to patients about their most basic health needs. And they leave with the conviction, the ability, and the efficacy to realize our most basic aspirations for healthcare. And the thing is, there's thousands of these folks already out there. So Mia Lozada is chief resident of internal medicine at UCSF Medical Center, but for 3 years as an undergraduate, she was a HealthLeads volunteer in the clinic waiting room at Boston Medical Center. Mia says, when my classmates write a prescription, they think their work is done. When I write a prescription, I think, can the family read the prescription? Do they have transportation to the pharmacy? Do they have food to take with the prescription? Do they have insurance to fill the prescription? Those are the questions I learned at HealthLeads, not in medical school. Now, none of these solutions, the prescription pad, the electronic medical record, the waiting room, the army of college students, are perfect. But they are ours for the taking, simple examples of the vast, underutilized healthcare resources that if we reclaimed and redeployed could realize our most basic aspiration of healthcare. So I had been at Legal Services for about 9 months when this idea of HealthLeads started percolating in my mind. And I knew I had to tell Jeff Purcell, my attorney, that I needed to leave. And I was so nervous because I thought he was going to be disappointed in me for abandoning our clients for some crazy idea. And I sat down with him and I said, Jeff, I have this idea that we could mobilize college students to address patients' most basic health needs. And I'll be honest, all I wanted was for him to not be angry at me. But he said this, Rebecca, when you have a vision, you have an obligation to realize that vision. You must pursue that vision. And I have to say, I was like, whoa, that's a lot of pressure. I just wanted a blessing. I didn't want some kind of mandate. But the truth is, I've spent every waking minute nearly since then chasing that vision. I believe that we all have a vision for healthcare in this country. I believe that at the end of the day, when we measure our healthcare, it will not be by the diseases cured, but by the diseases prevented. It will not be by the excellence of our technologies or the sophistication of our specialists, but by how rarely we needed them. And most of all, I believe that when we measure healthcare, it will be not by what the system was, but by what we chose it to be. Thank you.
That TED Talk really talks about aspirations, and not every community can have the health leads that were outlined, but we can aspire to that. And so we talk to students about really how social determinants of health are impacting the communities that they serve. I took a little deeper dive and realized, really for nursing programs, a lot of the times we don't even touch on the topics. So, looking at the literature, I identified there are about 1% of US undergraduate nursing courses explicitly teach social determinants of health concepts. Very little. Um, and we know that healthcare care professionals lack structured opportunities to address patients' social needs. And traditional education often fails to translate social determinants of health knowledge into practice. So, as is outlined in the TED Talk, equipping our nursing students to access community resources and to extend their care beyond the bedside maybe that spark that makes the difference between a healthcare outcome that is of greatest need for those in greatest need. So, how can we really operationalize this? One of the tools that we think about is looking at structured reflection as a way of engaging our students in their experiential learning, and really reflect on how to develop their skills in identifying and addressing social factors in health in the patient's care, and hoping to help them get to a healthy outcome. These experiential learning opportunities can be a time when they learn through a transfer of knowledge or that shared experience, bringing back into their, very uh, structured a scenario in a structured environment where educators can really give them a perspective on how to better address the concern that they or scenario that they've been presented with. So, in our simulation labs, for example, we explore with students a scenario and use a structured reflection to debrief and reinforce the experience in that simulation, and reflect on how then they can improve. And we ask questions of them of what went well with the scenario, what could they do differently next time? How can we better engage our patients? Can we use motivational um, interviewing with our patients to better have an idea of do they have the resources um, to really kind of address their issues, or have we been intentional about asking about the barriers or obstacles that a patient may have, and how we can help them address that. These scenarios really are ways that we can embed social determinants of health in the instructions that we give to students, um, a real life scenario, to better help them and give them the foundation and the equipment, the resources. So when they go into their into the workforce and they go into their positions, they are better equipped to deal with the patients and the environment they'll be exposed to. When we do our scenarios, we try to make it real life. We try to introduce them to a scenario that they really will step into. Um, and simply asking, what can you have done better? We can start there, but we want to really reflect with them and evaluate. We can bring in current events into the experiential learning environment and explore how could they handle this in a more favorable way. How can we make the encounter more favorable? And we have to really think about the context and the patient experience, and making sure that those marginalized patients, that we really think about their historical perspective and create a scenario where we show empathy and care, so that we can address the concerns that the patient truly has come into our environment to have addressed. So in that reflexive cycle, um, after the scenario, we think about, what are your thoughts? How did you really engage in that? What could you have done better? What things did go well? And also focus on those things that did not go well. What are factors that affected the outcome? And what resources can you identify that this community has, that you can really focus and provide to your patients? How can you reframe this scenario in a better light? What could you have done, like to have seen done differently? And then if we're really focusing on initiatives to address social determinants of health that may really think about the Dallas-Fort Worth area, think about those quality indicators that Dallas engages in to figure out what the inequities are. And then highlight for our students things that are unique to the community that you have there in Dallas, like Smart Dallas 2030, that really tries to bring in resources to address those inequities and engage in partnerships like with what you have with the University of Texas at Arlington, that really focuses on social determinants of health and researching those issues that come out of communities, and then partnering with public and private entities like Herzing University, and thinking about ways that we could reshape the experiences students have, so when they come into the workforce, they're better equipped to address the concerns of their population that they'll be serving. We identified some resources that students can engage in and create their own repository of resources when they're going through that windshield survey that we talked about previously, and think about the resources that they can identify within the community. So when they have an opportunity, they can pull forth these resources if there's an issue with the housing that the patient is experiencing, or if there is insecurity. It's hard to think about, taking an antibiotic or whatever the case may be when there's some issues with security of food for that patient, as an example. So bringing forth these types of resources are part of the ways that we engage students and have them think about the communities that they will serve, and give them resources so that when they go into the workforce, they can utilize these references to help address patients' concerns and hopefully lessen the health disparities within that community. So, in conclusion, I think that we are in a point in time where our education of our health students, particularly our nursing students, is critical, and we have to help them recognize that there are barriers to health that our patients and their families face. And our patients are from a diverse socioeconomic background, and we have to focus on those barriers that they face and think about how to engage in an empathetic way with this population, so that we can effectively screen for social determinants of health and then formulate plans and develop resources that help mitigate the effects of social determinants of health through referrals to these resources that we talked about, so that we can really address the health concerns and be more effective. Um, I hope this gives you some insight. These are the references that I used to develop this presentation. Um, and so I really thank you for giving me your time and attention. Are there any
Thank
questions?
you, Dr. Tyler. That was a terrific presentation and a great multimedia presentation at that. And we really appreciate you providing your expertise to our hospital members and friends. We had a couple of questions that came in, and I'd like to tell the people who are on, if you have some questions, type them in and we'll get to them. I got a question here. What are the most efficient ways to integrate social determinants of health screening into clinical workflows without increasing provider burden?
Great question. I think it is an intentional interviewing and integrating some basic questions about obstacles. If you are intentional about how to interact with your population, I think that lends itself to getting more information from the beginning. And then you can really explore ways of overcoming those barriers, obstacles with your patients. Engaging your patients in a shared plan of care as well. I think that's a very important way. Um, because if you get the patient's buy-in, as we all know, that helps with that plan that you develop. You have to really kind of recognize the strengths and weaknesses um, of your engagement with your patient and their abilities to meet the goals of the plan. So I think those are key ways of addressing it.
Well, it looks like we got a question here from a tech guru. What role can digital tools and new technologies, such as AI, play in addressing social determinants of health more proactively?
Well, I think that we're in a great space right now. And I think there are tons of opportunities with AI that we can explore. And I think we're only at the cusp of understanding how they can influence us. I can definitely take an example. At Herzing University, our nursing program has a platform that we use to help students engage in course content. It is called My Path, which is a resource that includes, texts, books, and multimedia to help engage the students on the topic. And embedded in that resource is AI. And students can engage, faculty can engage in AI to help, them understand concepts. And I think that same engagement with AI and helping our patients understand the health condition that maybe they are experiencing in a positive way can be a very good influence. It can help us explain things. You can use AI to help explain information that may have a high technical standard to a level of understanding that our patients and their families can best understand it, maybe giving them help us to idealize steps of engagement on something that the patient now has to learn how to do for themselves. I think we can use AI in a very resourceful way in engaging in meeting the patients where they are.
Okay, this is a good question. How can healthcare systems and universities measure the impact of the social determinants of health focused training and interventions on patient outcomes and workforce readiness?
That's a great question. I think partnerships are essential in helping to bridge this gap. I think that engaging um, nurses, physicians, um, instructors, professors, all of those stakeholders, engaging them in partnerships are a key way of bridging that and working within the community. Um, we often are looking at ways of being at the table to talk about the concerns of the community. And so those partnerships are a key way of doing that. At Herzing University, we have a lot of employee resource groups which engage in thinking about how to get inclusion within the community and to have a great impact. And I think if we work along those lines, um, I think that it will enhance our ability to address those social determinants of health in a positive way. And it's very important to really get engaged in the community's efforts to address those for those vulnerable populations that we work with.
Okay. How do you see hospitals, colleges, and community partners collaborating more effectively to address the social determinants of health at scale?
I think that again, that partnership is important. And I think if you work within um, small venues first, that really uh, helps to really move the needle, and then that can be compounded as its concentric value. So if we start with one hospital system that has a partnership that works towards meeting the goals of and the mission of that institution, that connects with a community resource. You start there, and you do that in multiple partnerships with small hospital interactions, and that will morph into um, an engagement within small communities that reaches out to the larger metropolitan area. I think that that is a good way to get started.
Okay, we got time for one final question here. How can
Mhm.
hospitals partner with universities to better prepare future clinicians to address the social determinants of health?
Hospitals are, I think, very at a strategic point of looking at engaging with universities, and Herzing University is very willing to engage and connect and provide a conduit to um, invite, your present employees to engage in further education. We have various programs available. If you're looking at, building a ladder of achievement for your employees, there are different opportunities that, for instance, Nursing offers from associate degree nursing to allied health programs to secondary nursing programs like MSN programs, and then we have a doctorate program as well. All of those types of resources can be made available to your employees as a way of improving educational attainment. And within that educational engagement, as I've outlined, we engage with our students how to address social determinants of health within our curriculum. And so that gives your workforce more ideas of how to transition and address, get engaged with the communities, pull out and think about community needs, how to research and think about those community needs, and in their roles, how to address it. And reinforcing to your workforce of getting engaged in um, community efforts, being mindful of being a part of the community's growth as a representative of your institution, as a representative of the university that they are attending, as a representative of being a part of the community. Being a part of the solution is always, I think, an engaging way of addressing social determinants of health, looking at the issues and being a part of the solution, whether it's engaging in further education, understanding what the social determinants of health as you get engaged with more information as a student, and then putting that information into practice um, as part of the workforce is going to be an important part of addressing health disparities and health inequities.
What a terrific presentation today, Dr. Tyler. Thank you so much. We really appreciate you providing your time to provide your expertise to our hospital members and friends. I wanted to let everyone know that we did record the presentation. I'm going to post online today, and I will send a link to everyone who registered for the event, whether they attended or not. Dr. Tyler has also graciously allowed us to have a copy of her presentation today. I'm going to send that out today as well to everyone who registered for the event. Dr. Tyler, any closing comments?
No, but thank you. Thank you for having me, and thank you for giving me a platform and an opportunity to share. And hopefully, if you have any questions, you can reach out and connect with me. I'd be more than happy to engage. Thank you so much.
Thank you, Dr. Tyler, and I'll make sure that all the registrants have your contact information when I send out the emails today. So thank you so much, everyone. We're going to end the webinar. Thank you, Dr. Tyler. Thank you to all of our attendees and the participation and the questions. It's been a great event. So thank you, and we will see you soon.